Recording. Thank you. All right. Hi, good afternoon, all. Welcome to our last April session of the Virtual Learning Collaborative, made possible in partnership with the CDC Division of Viral Hepatitis. My name is Zakia Grubbs, and I'm a manager on the hepatitis team here at NASTAD. Today's topic is on the Hepatitis C State of Medicaid Access 2023 Report Card Update. Joining us today are speakers, Dr. Adrienne Simmons, Director of Programs, National Viral Hepatitis Roundtable, and Thaddeus Pham, Viral Hepatitis Prevention Coordinator with the Harm Reduction Services Branch at the Hawaii State Department of Health, and our moderator, Alan May, Epidemiologist with the Arkansas Department of Health. The format for today's session is as follows. We will begin with presentations, followed by a Q&A discussion facilitated by Alan. Please feel free to use the chat to introduce yourselves and your jurisdiction, and also leave any questions that you may have for our presenters. All right, so with that, I guess we will start with Adrienne. Thank you.
Awesome, thanks, Zakia. I'm gonna share my screen. So Zakia said, my name is Adrienne Simmons. I use she, her pronouns, and I'm the Director of Programs at the National Viral Hepatitis Roundtable. I'm excited to talk to you all today about the state of Medicaid access as it relates to hepatitis C treatment across the country. Many of you may have heard this presentation before. You may have been following our work around this. By show of hands, or just give me a reaction in the chat, how many folks were able to attend our update on this in February? I'm curious if this is new information for most folks. See a couple of hands. All right, it looks like this may be new information for a lot of you. For the folks that have heard this before, thanks for bearing with us. A lot of it will be similar to what you heard in February, but I'm going to go through this information pretty quickly. I've got about 15 minutes, and Zakia, you'll have to help keep me honest. But there's a lot more content in here than 15 minutes will allow for. So feel free to pop your questions in the chat. You can grab my email off of the slide, and I'm happy to follow up with anyone after. But we're going to dive right into things. So in terms of disclosures, this program is supported by AbbVie and Gilead Sciences. However, the methods, research, and conclusions of the project are those of the Center for Health Law and Policy Innovation, as well as the National Viral Hepatitis Roundtable. They don't necessarily reflect the opinions of AbbVie or Gilead Sciences. We're going to go through an overview of what the project is. I will very briefly tell you why treatment restrictions matter, and then we'll dive into the fun part, which is our findings for the latest update. We'll close with some advocacy opportunities and, of course, have time for Q&A. So starting with an overview of this project, this is just a quick kind of timeline to give you an idea of where we've been as it relates to hepatitis C treatment access. So as many of you know, when direct-acting antivirals came to market in 2013, they came to market at a really high price. And so insurance companies immediately put restrictions in place to limit the number of people who could get access to treatment. Over time, we have seen a number of those barriers come down, and that's what we're really going to celebrate today. The progress, however, that we've seen has been both a combination of advocacy by people with lived experience and clinicians and viral hepatitis coordinators all over the country, as well as litigation when advocacy hasn't worked. And so we started formally tracking these restrictions when we launched this project in 2017. So we've got about 6 years of data under our belt and are excited to share with you today how far we've come. So as I mentioned, this project is in collaboration with Chilpy up at Harvard Law School, and it tracks the hepatitis C treatment access across all 52 state Medicaid programs. We gather this information based on publicly available documents that are published on Medicaid websites. These documents include clinical criteria, prior authorization forms, meeting minutes, and press releases. And so historically, when we launched this project 6 years ago, we were tracking 3 restrictions primarily: fibrosis or liver damage requirements, substance use requirements, and prescriber requirements. We also took a look at whether there was equal treatment access being provided between fee-for-service or traditional Medicaid programs and managed care programs that Medicaid programs often contract with. In June of last year, we started to expand the number of barriers that we were tracking, recognizing that the initial 3 barriers weren't sufficient. They didn't sufficiently cover all of the barriers that patients were facing. So in 2022, we added prior authorization as a whole, as well as retreatment and additional restrictions that include things like requiring the documentation of genotype. And so our website got a makeover. If you visited our website in the last few months, you'll see that it looks totally different. And so we would welcome your input on whether the utility of it is improved. It's got a new color scheme that hopefully makes it a little more user-friendly. So let us know what you think about that. All right, very quickly, gonna skim through why treatment restrictions matter, because this is absolutely preaching to the choir. You all know better than I do why these restrictions matter and how they impact patients' ability to receive care, because many of you are tracking and analyzing the data that provides the foundation of these slides. So very quickly, as you all know, hepatitis C infections are rising. And we see significant racial and ethnic disparities, with Black Americans and Native Americans having the worst mortality and infection rates of anyone. As hepatitis C infections are rising, we're actually seeing treatment rates decline. And so the CDC published data that showed that between 2015 and 2020, the number of people receiving hepatitis C treatment declined well below the target we need to be at in order to eliminate hepatitis C by 2030. They also recently published data that only 1 in 3 who have insurance receive timely hepatitis C treatment. When we look at Medicaid, that number drops to 1 in 4 among Medicaid beneficiaries. As you all know, this is a health equity issue, right? Not only are there significant racial and ethnic disparities, but it also disproportionately impacts people who live in rural areas, people who are unhoused, people who use drugs, as well as people who have a history of incarceration. These disparities are really widened by prior authorization requirements, which often require multiple visits or multiple points of contact with a very complicated healthcare system. There's some hope among all of the darkness. As you all know, there's been a lot of discussion at the federal level in the last 6 to 9 months about a national hepatitis C elimination program. I'm happy to get more into that should it come up in the Q&A, but one of the core pillars of this program, should the funding be secured for it, would be increasing the number of people that receive hepatitis C treatment. And I would imagine removing prior authorization would be a component of that. And so now on to really the meat of this project, which is our findings for 2023. I'll preface this by saying that our last update was done in February of 2023, and there have been some changes since then. So I've tried to make note of those on the slides, but the actual images that you're going to see for individual restrictions are the data that we found as of February of this year. And so here's a quick breakdown of what the grades look like. I'll move on to the next slide, but you're welcome to take a look at our website to see where your state is. Pictured here on the screen is a depiction of the overall grades. And so this takes into account all of the various restrictions that we track, and it assigns a letter grade to the state for access. And so the darker the red the color of the state is, the worse treatment access is. And then we work our way all the way up to green, which typically means pretty good treatment access. Since 2017, we've seen a lot of progress, which is great. 33 states have either eliminated or removed their fibrosis restrictions. 36 states have reduced their substance use restrictions, and 35 states have scaled back prescriber restrictions. Here is just a quick snapshot of some states that have made some significant progress since our June 2022 report. I'm going to skip over this as it doesn't include some states that have made changes in the last couple of days, but in the last couple of months. But certainly we're really proud to see how much movement there has been since we overhauled this project last year. And so diving into the individual restrictions, prior authorization is one of the most common barriers that we hear talked about today. And we've seen significant progress on this issue over the last 2 to 3 years. And so as of February 2023, there were 21 states who had removed prior authorization for most patients entirely. And 7 of those states removed that in between June 2022 and February 2023. So there's a lot of momentum around this issue right now. Since we published this update a couple of months ago, there's been additional movement. Florida removed their prior authorization requirement by implementing a process called Smart PA that I'll talk about in just a little bit. And we've also heard that there are a couple of other states that have either voted to remove prior authorizations or are very close to removing them. So New Mexico is currently revising their policies. And I just heard this morning that Pennsylvania's Drug Utilization Review Board just last night voted to remove prior authorization. These decisions still have to go through a couple of other layers before they're official, but we could soon have, nearly 25 states so almost half of the states in our country removing prior authorization, which is a big deal. Looking at fibrosis restrictions, we only had 2 states in February that still imposed a minimum liver damage requirement, with those 2 states being Arkansas and South Dakota. I'm excited to share that as of April 1st, South Dakota removed their fibrosis restriction, leaving Arkansas as the only state that still imposes this requirement. So we've made significant progress around this barrier in particular since this project launched in 2017. When we look at substance use, this map, if you looked at it 2 years ago, there would have been a lot more dark red colors, a lot more dark red states on this map. But we've made progress here too. Despite the progress we've made, this is probably the most pressing and widespread barrier that remains. So there are 5 states who still require a minimum period of abstinence from alcohol and other substances, either prior to or during treatment. There are 8 states that require a provider to counsel a patient on substance use prior to treatment. But we've seen a significant reduction in the number of states that impose substance use requirements overall, which is super important as we think about the communities that are disproportionately impacted with hepatitis C today. And again, South Dakota, since this map was released in February, South Dakota has also removed its substance use requirement. So when we do our next update, they will be light red instead of dark red on the map. When we look at prescriber restrictions, this is another pretty widespread barrier that we saw in 2017, but again has been significantly reduced over the recent years. So there are 6 states that impose prescriber restrictions for initial treatment or require some sort of a specialist involvement for treatment to be prescribed. It's listed here that Arkansas requires the prescription to be written by a specialist, but you'll see in the report card that they actually allow prescribers who are not specialists, but who are working directly under the supervision of a specialist to also prescribe treatment. And then Puerto Rico allows primary care physicians to prescribe only if they undergo additional training and certification. And so we have categorized that as a prescriber restriction currently. Looking at retreatment, so there are a number of states who restrict who can be treated multiple times for hepatitis C. This includes lifetime restrictions on treatment. So some states say you can only have 1 course of treatment in your lifetime, and others may have policies that are more restrictive than the treatment for initial treatment. And so, for example, they might say that if you are seeking treatment for a 2nd or 3rd time, that you have to be enrolled in a substance use treatment program, as an example. So this is a pretty common barrier that we're seeing across the country. We're also still seeing some challenges in managed care organizations that are imposing more stringent requirements than the fee-for-service program dictates. Some states may have very strong and positive fee-for-service policies. They may have even decided to remove prior authorization for most patients, but they may have poor managed care enforcement. And so New Hampshire is an example that we've highlighted here, where on the surface, it looks like the state has really great access, but in practice and on the ground, what we're hearing is that that may not translate to patients that are enrolled in managed care organizations. I mentioned that there were some miscellaneous restrictions we were tracking, like the documentation of genotype or the required documentation of chronic infection. This is just a quick snapshot of the miscellaneous barriers that we have seen across the country. And so I think one of the important things to think about is that prior authorization alone, while yes, it is a huge barrier to hepatitis C treatment access, removing prior authorization alone will not magically increase access to treatment. We've heard loud and clear from providers and patients that specialty pharmacies continue to be a challenge. They often reinforce many of these barriers to treatment. And there are a variety of challenges that are listed here. We won't talk through them all, but I think it's important for folks, particularly coordinators, to be aware that prior authorization is kind of the first major barrier. It's the low-hanging fruit sometimes in treatment access challenges, but there are many more challenges that come with getting medication into a patient's hand. And so there are very frequently insurance companies that will require patients to use a mail order pharmacy or to use a specific pharmacy. And this can pose challenges to people who are unhoused or people who don't have stable access to a phone. Many of the processes within specialty pharmacies require making contact with the patient before they will mail a prescription out. Sometimes they will only mail to a residential address. They won't mail to a clinic or a shelter. There are often dispensing limitations. So often you can only get a month of medication at a time, which is sometimes challenging for folks who, again, have trouble accessing our healthcare system with relative frequency. We have two states, Connecticut and Maine, that actually have 14-day limits within their Medicaid programs. So imagine having to get any prescription that you're taking refilled every 14 days. It's really, really challenging. There are lots of solutions to all of these issues. Certainly, some of these issues are tied to pharmacy benefit managers and needing to reform our system more broadly, not specific to hepatitis C. There are states, though, that have allowed medications to be filled by non-specialty pharmacies. So Louisiana and Virginia are two examples of that, and that's just an administrative decision within the Medicaid program. We've also seen states decide to allow the full treatment course to be dispensed at once. And so Colorado will actually allow patients to receive up to a 90-day supply of medication at one time. We're seeing some states employ some innovative prior authorization mechanisms, and I flagged this just as something, if you live in a state where they're very resistant to removing prior authorizations, perhaps because of financial concerns, there are some mechanisms, some workarounds that really function as a prior auth removal. And so there are these new programs called Auto PA or Smart PA that essentially uses the pharmacy software to implement some automated criteria in the background. And so specific requirements around age or diagnosis or previous therapies. And if all of the requirements are met when the prescription is sent to the pharmacy and they run the prescription through a patient's insurance, it will go through without needing to have a manual prior authorization submitted. And so to date, we have both Indiana and Massachusetts having implemented these processes, and Florida was the most recent addition to this list. And so this might be an alternate strategy in states that are hesitant to remove prior auth altogether. We're also seeing a growing number of states that have a single preferred agent, and we'll probably get into this in the Q&A, but a number of states have a single preferred agent on their preferred drug list. Many of these states have done that through what's called a subscription model or an innovative payment model. So 5 of those 10 states have those models in place. What a subscription model is essentially they have a contract with the pharmaceutical company, and you can buy an unlimited amount of medication at a fixed price. So it's a way for Medicaid programs to be able to better predict how much money they will be spending on direct-acting antivirals. And so despite all of these policies changing, many policies changing across the country, awareness really lags about the fact that these policies have changed and patients who were previously ineligible for treatment may now be eligible. And so we really encourage states to send letters to providers and to conduct outreach to patients to make them aware when these policies change. Not only can departments of health be helpful in these efforts, but clinics and medical societies, provider training programs, community-based organizations, and state coalitions can all be effective partners and messengers in helping spread the word. And so with that, I'm going to close with some opportunities and threats. I mentioned that there's this talk of this national hepatitis C elimination program that might address some of the prioritization barriers, although it's a little bit too early to tell because we still have to get the funding for it. There was recently a study published that showed that dispensing the full treatment course at once, in addition to a couple of other strategies, was really effective at achieving high cure rates. And so I would imagine we could see some additional states allowing for the full treatment course to be dispensed at one time. We're seeing movement in treatment access in correctional facilities. So California recently had approved their 1115 waiver for Medicaid, which will provide people who are incarcerated with Medicaid coverage 90 days prior to their release. And then certainly there are silver linings of the pandemic around that may allow us to bring rapid diagnostics to market, as well as to expand telehealth for hepatitis C treatment. But of course, there are always threats on the horizon as well. The public health emergency will be expiring soon, so it's unsure how that will affect Medicaid coverage. We have a number of states that still haven't expanded Medicaid, and so there are many adults who are uninsured. We continue to see threats to the 340B program, which is used to fund access to hepatitis C services in a variety of programs across the country. And then certainly the focus of our program has been on Medicaid, but we see similar challenges in Medicare and commercial insurance. And so my call to action to this group is really to ensure that prior authorization removal is included in your elimination planning process. There have been states that have been successful at making movement on this issue by tying it to their elimination plan goals. So be sure that you're convening stakeholders who are really passionate about this topic and who can make the case for removing it in your state. And then certainly we call on all state Medicaid officials to review and update their policies. Again, nearly half of state Medicaid programs have removed prior auth, so there are plenty of peers to talk to and lessons learned at this point. So please do reach out to your neighboring states and see how they were able to make this happen. And so with that, I will close here. Prior auth is, a moving target for sure, but removing it offers an exciting opportunity for states to increase access. We've made a lot of progress, but there's more work to be done. And many of these restrictions are rooted in stigma and discrimination. So we need everyone's help in removing these barriers and eliminating hepatitis C by 2030. So with that, I will wrap things up and turn it over to Thaddeus.
Awesome. Thanks, Adrienne. And I'll just go ahead and share my screen real quick. Awesome. Well, I'm going to start with a question, and Adrienne actually provided a great contextual overview of kind of what's happening nationally. And we're going to give a shout out to Adrienne and the NVHR team a lot during this talk. But let's start with this question, which is a question that we had to consider. And as I had to kind of consider as I put this summary together for you all is, what can you offer? And this is what we thought about. What can we offer as we try to push for prior authorization removal, right? I think something that's important for us to know is, what we can bring to the table, and also to highlight that we are experts, that we do have a lot of things to bring to the partnership when we're trying to remove prior authorization. So this is a little reminder, I think, for ourselves in Hawaii, but perhaps for you folks too, is, just to get ready and stay ready. Even if your Medicaid programs are not at that place, or you're still working through all those different kinks that Adrienne had mentioned, for example, like specialty pharmacy issues, it is really helpful to have things ahead of time. And I'll mention some things. I'm more than happy to share the documents and materials that we've created that were helpful for us. So please always reach out, and you can see my contact information there. I'm also going to just note something that one of my favorite former viral hepatitis prevention coordinators said before they presented, and they opened their talk with, with a quote, and that's "Comparison is the thief of joy." And I want just to remind everyone that this is very specific to Hawaii and what we learned. Perhaps it will provide models or ideas for you all, but really just to also know, if you aren't at the place where your state has removed prior authorizations, that there is still opportunity. And, just to note that we all are working in our own different cultural and state contexts. So give yourself a little bit of grace on that. But so what do we have to offer, right? So the first thing that we know in Hawaii that we can say is that we have data showing that we can save lives. And I think that was a really important spin or sticky message that we could say is we are trying to save people's lives in Hawaii, right? So you can see here, this is data recently from a report that was actually on Hep B, but also included liver cancer. And you can see over 20 years in Hawaii, using CDC data, we're able to show that the liver cancer mortality rates for Hawaii were higher every year compared to the rest of the US. So we can show that there is some sort of burden related to liver cancer in Hawaii. We also know, according to a recent CDC article, that, or actually a previous article from our liver transplant center, is that 2 out of 3 liver cancer cases actually are due to viral hepatitis, right? So we're showing that there's more liver cancer mortality in Hawaii compared to the rest of the US, and that most of that is due to viral hepatitis. Now, this is the CDC article that I wanted to mention, which went state by state and looked at Hep C associated mortality. And the striking thing, and I confirmed this with the authors, is actually Hep C associated mortality in Hawaii means that you will die on average 20 years earlier than everyone else in the state, right? So you lose 2 decades of life due to Hep C infection. So this is really powerful. And again, we are just reiterating that this is important because we are saving lives and giving people back on average 2 decades of life. We also show, Adrienne mentioned the inequities that had come up. This same article, when we looked at it, we noticed that Hawaii actually the highest proportion of Hep C related deaths among Native Hawaiian, Pacific Islander, and Asian residents. So again, this is an equity issue, it's a life-saving issue, and this is kind of the message that we use. And again, you might notice that I didn't use any surveillance data because we actually don't have robust surveillance infrastructure, but we were still able to pull forth data that was local and that was powerful enough to start this discussion, right? Something that Adrienne also mentioned, I feel like Adrienne just really set it up for me. So the second thing that we have, right, something that we can bring to the table is that we have a plan, right? So we have a strategic plan called Hep Free 2030 on how we can eliminate hepatitis in Hawaii by, I guess, in the next 7 years. This is just details, so I'm going to skip this, but just to note that we have part of our mission and vision and our values moving forward is really, again, important to note that, that all of this bears in our discussions with our Medicaid folks and removal of prior authorizations, right? So this work means that we're reducing harm, we're hopefully improving social justice, addressing intersectionality, and approaching things with aloha. And not only the value of aloha, which is love and acceptance and all the things that that come with that word, but also acknowledging the place and the people with whom we work in the Native Hawaiian community. So this is our plan. This is our wheel of priorities, right? A lot of times folks would think that we would only talk about prior authorization removal in the context of this priority, access to services, access to clinical services. But really, when we started to do the work with our coalition, we saw that it touches on all priorities, right? So when we talk about prior authorization removal, means that we have to integrate it into our awareness and education messages, including social media. Of course, it becomes an advocacy issue working with our Medicaid policy folks, but also talking to our state legislators about how we can really prioritize hepatitis elimination, including prior auth removal as a statewide priority, right? Of course, equity in everything we do. So I showed you earlier how this disparately impacts Native Hawaiian, Pacific Islander, and Asian people in our state. And of course, using data for decision-making, right? So we're not just saying that this is an issue, but we're kind of justifying with the data that we have at hand, as I showed you. So we're showing that we can save lives using data. We're showing that this is integrated into our statewide plan, which was blessed by the health department and over 100 different community partners. So what else do we have? Well, we have those partners, as I mentioned, right? So I'm going to show you some of the key players that were helpful in us removing the prior authorization this past year. So of course, the Department of Health, Hep Free Hawaii is our coalition. It's 13 years old now, which is really, no, 12 years old. So we're a dozen years old. And I think this is what really allowed us to do a lot of great work, because it allowed us to build relationships over time. And again, this is why I just wanted to make that note about comparing yourselves to other states. Sometimes you have to know it takes some time to kind of build those relationships to move forward. So we are lucky enough to be doing this work for about a dozen years at least. NVHR, so National Viral Hepatitis Roundtable, so thank you, Adrienne. NASTAD was really helpful in moving this forward, so thank you all the folks from NASTAD. And the CDC, actually our CDC project officers gave feedback on a lot of the justifications and the research and the data we were trying to pull to have these discussions with our state Medicaid. So I would say that our CDC project officers were also instrumental also in moving this forward, because we could also say that our CDC allies were seeing this as a priority, and they had contributed to our work in terms of moving this forward. And finally, this is the logo for our state Medicaid, or what we call MedQuest. Okay, so what else can we do? Well, we can do better, right? We know we can help improve things, and we can also make things look better too. And I highlighted that because really optics, I think, was what for us was really helpful in pushing things forward in Hawaii. But what did we do to kind of make this happen? So we prioritized prior authorizations as an important issue in our coalition, and by virtue of that, in our health department. So what we started to do in 2022 was document delays. We created a really simple, shareable online survey where providers could enter issues around delays so we could track it over time. So we had some body of evidence to show that there are these delays in care because of prior authorizations. I mentioned a little bit already, but we also built a case. So we actually have this long document that we call internal talking points, which are just literature, data, things like other states that have removed prior authorizations. And that was kind of our big working document, which I'm happy to share with anyone who wants it, to kind of build the case, right? Next, we convened partners. So we brought together all of our folks, not only providers, patients, advocates, and Medicaid folks, and the national partners that I mentioned, but also our insurance payers. And some of them were really willing to talk and give us insight in terms of what would help move them forward, specifically the 5 contract managed care organizations that are funded by our state Medicaid. And then finally, as I mentioned before, right, optics was a big way that we were able to move things forward. So I'm going to focus on that, but if you have any questions, please feel free to ask at the end. So one of the ways that we were able to drive the narrative or highlight the optics was actually thanks to NVHR and Chilpi. So they released this press release back in June, just saying, wow, there's a lot of work to be done, right? And we looked closer, and Hawaii got a D grade on that report card, which we were actually, at least on the coalition side, very excited about, because this gave us opportunity to push, right? We could say, we are not doing well. Look at this report card. How can we use this to better services and save lives? This is just a rundown, which is actually really helpful. So again, thanks to Adrienne and the team, highlighting where the points were, I guess, removed or not, where we weren't doing as well, with specific kind of recommendations and highlights. So this is very helpful when we started to talk with our Medicaid folks in terms of what exactly could be changed. This is a quote, which I'll read really quickly. This is an email I sent to our coalition folks, just sharing this press release and highlighting our grade. I said, sadly, Hawaii received a D score, so we have work to do. If you would like to help improve our score, please review the attached and let us know how you would like to be involved, right? So you could note that the way I framed it was, this sucks, but we have opportunity to make this better, and we could do this through collaboration. And we did this knowingly because one of the folks on this massive email list for our coalition emails was our state Medicaid. And they had never really responded or engaged before, but As soon as we sent out the email, like literally, I think it was that day, the head of our state Medicaid responded and said, wow, this is a major issue. We really want to address this. So there was an immediate response, which we jumped on right away. I will note, as you can see here, and also to give us everyone a little bit of grace as you try to collaborate with our different partners, the actual meeting to discuss this was delayed by a few months. So we started an email discussion in June. They're really excited. We continue to check in August because they're implementing other kind of things. We scheduled in September, and then that was rescheduled to October. So we were persistent and really, aware that they had a lot of other things doing, but we did not forget that they had committed to addressing this issue. But how do we kind of keep this optically in the public eye and in their eye, right? So to make sure that people are still aware and that so our Medicaid partners did not forget that this was an important issue. So later that month, we issued a press release through the Department of Health and Hawai'i, our different partners, just saying, hey, we got this grade. We would love for Hawaii to do better, right? So we highlighted this as an issue. Again, any of these I can share with you if you want to draft this template. We also work with NVHR and their partners who they're able to contract, and also the Hawaii Health and Harm Reduction Center, which is one of our biggest harm reduction agencies, or actually the biggest harm reduction agency, to put out an op-ed so that we could also continue to have this discussion and promote it and put it forth in the community. So you can see here the importance, again, of removing hepatitis C treatment barriers. And this is in August, so we can keep it top of mind. And finally, in doing so, I think we were able to not only prioritize it for us in the coalition, but again, prioritize it as an opportunity for our state Medicaid to move forward as well. So when we finally got to meet them in October, this is what we could offer. We could offer that we can help you improve quality, right? We're going to help you so much. You don't have to do a ton of work. So the first thing we offered to do is we can draft a memo for you. We could take the previous memo that they had sent out a few years ago on removing certain restrictions. And we said, you know what, we can update it. We can improve the D grade. They're very excited. They went through each of those line items on the D grade and they said, we can do this, we can do this, we can do this. They said, we won't remove PA, but we could probably do everything else. So what we did on our end at the Department of Health and Hawaii and other folks is we drafted a memo and we still put in removal of prior authorizations because why not, right? They're going to get a chance to edit it anyway. After we sent that, we still had, we're kind of looking at plan B. So we're talking with our individual managed care organizations who are still really interested and became champions. You can see here I noted Aloha Care on the right, who proposed this idea of a gold card, an alternative way of dealing with PAs, where they're like, maybe internally what we can do is create a mechanism where we pre-approve providers so that if we know a provider, for example, will abide by ASLD guidelines, has participated in a Hep C echo, and through our internal compliance, mechanisms, if they meet these 3 criteria, then they will automatically get waived for PAs for hepatitis C. So this is called the gold card thing that we help them draft and propose to them. Meanwhile, we can show thanks, right? So we're like, this whole time, there's some delays. We're wondering when they're going to get back to us on that draft memo. We're still trying to do the gold card, but unbeknownst to us, they didn't, surprise, happy holidays. At the end of 2022, this memo came out after we had just given a little bit of feedback, and they had noted and addressed almost all of our requests, including some language on prior authorization removal. So you can see here I highlighted 4 treatment regimens following the ASLD, IDSA, HCV guidance. There will be no prior authorization required, right? Well, this is really exciting for us. We were like, well, this is great. We didn't even know. Thank you for, at least it's out there. So the end of last year, they were able to put forth this official memo that kept most of the draft language we proposed. It really focuses on adherence to the ASLD guidelines, which pretty much all our providers already do. It limits managed care restrictions, so they couldn't be more restrictive than what was put forth in the memo. However, they did have language on an approval process to waive PAs, similar to that gold card I had mentioned. And this is actually the sticking point that we're dealing with now, because they're trying to figure out the mechanism for this approval, right? So currently, the PAs are still effectively in place until they figure out this mechanism. However, we wanted to acknowledge, again, optically, that change could happen, and we wanted to thank our partners. So we did put another press release in January saying this is great, we're moving forward. We also noted there's still opportunities for change. And you can see here, as Adrienne had shown earlier, this is Hawaii was now an A grade, and we are still moving forward to kind of address all those other issues that Adrienne had mentioned, including specialty pharmacy. So we're able to do a lot of things. We're able to bring a lot to the table, but we also acknowledge there's things that we can still do. So these are future things that, or actually current things that we're working on. So one is implementing the gold card, even though that PA memo came out, as I mentioned, effectively nothing has changed. I literally got an email right now, or right before this, where someone thought that the approval went through, the patient got a month's worth of medications, and then after they got the medication and started them, the MCO sent them a letter saying, actually, this is not covered, it's not on our formulary, so you're gonna either have to pay or we're gonna stop the medication. So the patient, if they don't want to pay, will effectively have to stop their treatment halfway through. So these issues continue. So we're hoping to still have some sort of gold card, at least with the individual MCOs. Something that our clinical providers recommended to make that approval process easier is just to have an attestation where a provider can just submit a letter saying, I agree to abide by the ASLP guidelines. And so that you don't have to show anything else other than that, especially considering that providers for managing complex HIV or diabetes cases aren't required to do, as much as they're requiring for hepatitis C treatment. I mentioned partnering with single MCO for the gold card. We are also going to convene in July for World Hepatitis Day, our coalition, and there's no movement then. We are going to be drafting a sign-on letter from all of our different community partners and providers to send to the governor and to the health department to note that this has not been implemented in the 7 months since the memo came out. And finally, I just hinted at this, but we are going to have a legislative briefing with our state legislators where we'll highlight the successes and the challenges of hepatitis elimination in Hawaii, and this is where we'll likely mention this again. So I'm going to just end with the question that I started with. So, what can you offer? And I think you can offer a lot, and maybe you can also offer anything that we might have done or shared. So feel free to reach out to me if any of these materials might be helpful to you. Otherwise, I'll turn it over to Alan to moderate our Q&A. So thanks, everybody.
Wonderful. And I get to do the easy part since Thaddeus and Adrienne have taken all the hard parts. And I also wanted to start by thanking both of you for a good presentation. One thing I will add for the audience is we drafted a couple of questions that were possibly discussion questions we could consider, but keep in mind, the presenters have seen these questions. If you want to surprise them, you have to come up with your own questions. So consider that. And we'll ask those first before we get to any of the other ones, if anyone wants to type in the chat or raise their hands. Thaddeus, one thing that is interesting, especially to those of us who come from the epi side, is thinking about how you all provide data to your Medicaid, how your Medicaid provides data to you, and or more broadly, what data was used to make these decisions, and how were you able to support your Medicaid program as you did that?
Yeah, this is a great question. And like someone once told me, don't get mad, get data, or get mad and get data. But so the great thing, and this is why I really emphasize that optics part driving the narrative, they didn't actually ask for a lot of data. I mean, we prepped ahead of time. We had all our talking points, we had all of our lit reviews, but I want to thank Adrienne again, just that making them aware of that D grade that was looked at nationally was sufficient for them to move forward. And they didn't even discuss or ask for data on our end. Which is great also because other than what I've showed you, which is really solid data, we don't have robust surveillance, so we didn't have much to share. But I'll also note that we do use a lot of qualitative data. So we're able to share and bring in our partners who are care coordinators, providers, and patients to share their experiences, which I think also is an important, non-quantitative data opportunity.
Yeah, and y'all have done a lot more than many jurisdictions I know with trying to figure out when your surveillance data is poor, what can you use instead? And I'm glad that you emphasized that. And Anne points out that yes, qualitative stories and impacts are often useful as well, in addition to pulling numbers. Adrienne, one thing that I wanted to hear about, and that you pointed out, you discussed some with the specialty pharmacy restrictions, is for a lot of us from the health department side, I think we probably have only a slight understanding of how Medicaid programs are administered. So, what barriers or facilitators to treatment access are probably not obvious to us that you would want health departments to think about, but that they may not know about starting out?
Yeah, there are two kind of big things that come to my mind. The first deals with how the Medicaid program is actually administered. So I think it's important to know, do you live in a state that contracts with managed care organizations? Because ultimately those managed care organizations get to make their own treatment criteria decisions. Legally, they're not supposed to provide more stringent requirements than what the fee-for-service program sets, but we've seen in many cases over the years that may not always be true. And so the fee-for-service program policy may say one thing, and the MCOs may all do something differently. And the way that they administer their program can also vary. And so I think it's really important to have an understanding of how the Medicaid program is set up in your state, and because that ultimately tells you who is the person responsible for making the decision around this, right? You can talk to the person at the state Medicaid office till you're blue in the face, but ultimately, if 90% of Medicaid beneficiaries are enrolled in an MCO, then you need to be talking to the MCOs, or someone within the Medicaid program needs to be talking to the MCOs. So that's super important. The second component of that, as it relates to understanding how the Medicaid program works, is understanding where these decisions get made. And so there are various committees within Medicaid programs that are typically made up of physicians and pharmacists that work throughout the state. Some of them may have hepatitis C experience, but the majority of the time they don't. And so figuring out who is the committee that's actually responsible for making recommendations to the state Medicaid program will tell you where to direct your efforts. Sometimes it's not even the committee that has the decision-making power. A committee might exist, but it might be the pharmacy director that holds the keys. It might be the medical director that holds the keys. So you've really got to do some kind of internal fact finding to figure out who's ultimately responsible for this decision. And then the last thing that I'll say is the specialty pharmacy piece is so critical. We could have an entire presentation about the specialty pharmacy component of this, but I would really encourage folks to learn more about this issue, because as you're pushing for prior authorization removal, it's also an opportunity to be pushing for medications to be dispensed in non-specialty pharmacies. I mentioned that Louisiana and Virginia have just made those decisions, and that can be a really important barrier removed for patients that are trying to access treatment. So I would get an understanding of what that looks like in your state. And that's certainly related to the MCO component and what pharmacies they contract with. It's all interrelated, but it's complicated. The last thing that I'll just say is that, some people think removing prior authorization is going to automatically open the floodgates and people will just, start to get treated, by the masses. That isn't true. Ultimately, you've got to invest in outreach. You got to invest in testing. It doesn't matter if someone can get their prescription without a prior authorization, if they don't know their status, or if you haven't reached out to them to say, hey, this policy changed. You might have been diagnosed 3 years ago and couldn't access treatment, but now you can. So we've got to invest in both outreach and look back programs to identify people that have been previously diagnosed but may not have been treated.
Alan, can I also add to what Adrienne said? Because Adrienne brought up such good points that are like, what is it? So to speak to what Adrienne is saying, I think, as soon as prior authorization removal happens, I think you had mentioned testing and also provider training. We found that it is a major issue also. So increasing the infrastructure of treatment. And 100% what Adrienne said is working with MCOs. We have one particular MCO who sees most of the patients in Hawaii who are Medicaid. So, they hold, in a sense, more power and more clout. So working with them or individual MCOs is really important. And also, again, I'll reiterate everything Adrienne said, but that specialty pharmacy comment is really something that's important and has been a major issue for us.
And I'm glad you brought that up because, yeah, I mean, I'm sure you cannot make a policy in Medicaid in a state that relies heavily on MCOs without having the MCOs buy in. And there are some states, like I think Louisiana, has actually made various Hep C specific quality improvement measures imposed by their Medicaid program for their MCOs. That does make me wonder, like what Thaddeus is describing, where the state health department works directly with the MCO, or what Louisiana has done, where Hep C is specifically in the quality measures that are documented for the MCOs. Is that common in a lot of jurisdictions that the MCO contracts specifically discuss Hep C? I mean, there are some, I'm sure, that carve in or carve out Hep C drugs, but is that in most MCO states or is that rare?
It's pretty rare for states to carve out hepatitis C medications from MCO contracts. I would say if I had to put a number on it, it's probably a quarter to a third that carve out medications. And a majority of those do so because they have that subscription model contract. And so the pharmacy benefit for Hep C medications all goes through the fee-for-service program. But, ultimately you're absolutely right that the relationship with the managed care organization is critical. They are ultimately who is making the decision about who can or cannot access treatment. And so without a strong relationship with them, it's really difficult to make progress on this issue. There have been some states that have made progress in working through, some states have like a managed care association. And so that regularly interface with MCOs. And so that can be a really helpful partner in this issue. But ultimately, you can't do this work in a state that has MCOs without buy-in of MCOs.
Yeah, and also while still working with our state Medicaid, right? Because sometimes the MCOs will be like, "Oh, we can't do this. This is what they told us because the Medicaid hasn't issued new guidance." So that's why the memo helps us, but we still have to now work with our MCOs to actually implement what the memo put forth.
And I'll just say one more thing on the MCO topic is that keep in mind that many of these companies that administer managed care programs also have large commercial plans, right? So like the Anthems of the world. And we actually see worse access in commercial and Medicare plans. Medicaid in some ways is ahead of the game in removing some of these restrictions. So sometimes it's just that whatever policy they have for their Medicaid managed care, it's because that's the policy they have for their commercial beneficiaries. And so we've got to do some more work. And I will also say that, for the most part, states aren't intentionally trying to restrict access to treatment anymore. Some have very real, cost concerns that is an artifact of, Hep C treatment having a $100,000 price tag 10 years ago. But sometimes these restrictions are just like artifacts. They just haven't revisited their policy. It's not because they're actively trying to restrict access to treatment. So I would say go into these conversations with, assuming positive intent, and wait for them to give you the reason as to why they're restricting treatment so that okay, what is the data that I need to provide them to assuage whatever concerns they might have.
And Anne has noted in the chat that she's not in favor of the floodgate philosophy, which I mean is probably true that was more true in the early years of Hep C treatment when there were a lot of people who had been waiting for DAAs to come out. Thaddeus, one thing that you have brought up a lot that I suspect some jurisdictions are having trouble with, and that we certainly are still working on in Arkansas, is how to have good participation from patients and from providers when you're making these planning decisions. Because I mean, the state will make bad decisions if it gets no public input. That just is always true. And so how did you make that happen productively? And what did you hear from patients and providers that you didn't expect, and that, changed the way that you thought about what you needed to do?
That's a great question. So I think I mentioned this, we're lucky in that we had started our coalition 12 years ago. So we had a lot of relationships with patients and providers over time. So we're able to kind of build on that. We did convene, I think this is literally the week after the NVHR report came out. We had scheduled the convening with patients and providers and insurance payers to discuss this. So that was already kind of in the works because we were talking about it. So having a convening where everyone shares their feedback was really helpful. And also to have the insurance representatives hear directly from people. And this is where some of them started to be like, oh, well, why don't we figure out other workarounds while Medicaid is still kind of moving forward. Things that we had heard that were surprising. I think it was mostly what Adrienne mentioned around specialty pharmacy. They're like, you know what, even after prior authorization was removed, they have a short window to fill their prescription. And if they don't meet that window, they'll have to reapply for the PA or resubmit a PA, right? And given that a lot of our patients in the syringe exchange were not always able to get there at a certain time, in their lives, that meant they had to submit multiple PAs in order to get access to care. So that was something that was really important. So the pharmacy discussion comes up a lot for us.
Throughout this discussion, money is always in the background, and something that, we have wondered about in Arkansas, and I suspect some other jurisdictions have as well, is, we know, that when DAAs are cheaper, access is easier. If DAAs were cheap from the start, we wouldn't be having this discussion. We would have a different discussion. And we also know that when you prescribe DAAs, you have a big upfront cost, and then you recover some or perhaps all of the costs later on. But that's very hard to estimate, what the cost impact will be. In the last few minutes, do either Thaddeus or Adrienne or others on the call, do y'all know of states that have done a great job of assessing those cost impacts fully, accounting for both the upfront costs and the recovered costs later on? Or are there good practices that should be highlighted with that? And then also, before we get into that, NASTAD has also asked if I can please remind everyone that there is a survey for you all to fill out evaluating these calls, and you are encouraged to do that and provide good feedback so that can be taken into account for future sessions.
I don't know any states that have done cost analyses that have been public after removing prior authorization, but I'm sure that there is someone in the Medicaid program that's keeping a very close eye on that. So, anything around drug spending is very confidential and contractual in many cases. And so I would encourage folks to reach out to states that have removed prior auth and have peer-to-peer conversations around these issues, because again, I know that people are tracking this. And I think it's important for folks to continue educating people that hepatitis C treatment doesn't cost what it used to cost. I'll put a link in the chat to a fact sheet that we published a couple of months ago that talks about the cost now, which is significantly cheaper. It's still not cheap, but significantly down from what it has been. And that often is what people remember, is the $1,000 pill a day that was very much a reality in 2013.
Okay. Well,
I just shared a link
want
to an article that
go
we
ahead, Thaddeus.
No, I just wanted to know, I put something in the chat.
Okay, very good. I don't want to keep people past 3, but I do want to reiterate thank you in particular to Thaddeus and Adrienne for a good discussion, and thanks to NASTAD for organizing, which is very helpful.
Yes, thank you also to Alan and our presenters so much for this discussion today. We will be meeting again for our VLC on May 3rd to talk about negative and undetectable HVV DNA and HCV RNA. So we'll see you all then, and thank you all so much for joining us today. Have a good rest of your week. Thank you.
Thank you. Bye.